Senior Director for Advocacy at Medicines for Malaria Venture. And I'm very glad to welcome you to this event, which is on the intersection of women's right to science and innovation and right to health, and which we co-host with Speak Up Africa and the Treatment Action Group. I will start maybe with a few points of practical interest. The meeting will be recorded for your information, and there is interpretation in French that you can activate if you click on the globe, which is on the bottom of the screen at the center, and it's actually written interpretation. Also, please mute your microphone when others are speaking, and during the discussion and the presentation, put any questions or comments in the chat box. At the end, we will collect these questions and we will have a discussion, and you will also be able, if you prefer, to raise your virtual hand and ask the questions or make the comments directly. There is also a special point for the participants who join actually this event from the registration web page on the NGO Forum, the CSW NGO Forum, because we don't have visibility on those registrations. So for that group, if you have not registered through the MMV link, please put your name and organization on the chat box so that at the end we will have a comprehensive view of the participants list, and we will be able to share information on the follow-up if you want to receive it. So that's a bit the initial practical piece, and I would like to kick off and introduce a little bit the background to this event. So the Universal Declaration of Human Rights, as well as the International Covenant on Economic, Social and Cultural Rights, both recognize the right to health and also the right to science, which include a very important the right to enjoy the benefits of science. In particular, the Beijing Platform of Action makes an explicit reference to this when it recommends among the strategic objectives of the platform, eliminating gender biases in research, including in clinical trials involving women, and paying particular attention to improving access to innovative technologies and treatments that address women's needs. So this year is an important year because there is the review of the 30 years of the Beijing Platform for Action at the Commission on the Status of Women. So we thought that this was an important opportunity to to understand what progress has been made and what gaps remains in connecting actions on the right to science and the right to health, with a focus on women. And we are then particularly pleased to have this opportunity to deepen our understanding and also maybe, hopefully, to create a community of interest and a community of advocacy on this specific topic. We have the great privilege of having a panel of experts and advocates that will help us in taking forward this effort. And I wouldn't like to take any further time and maybe start by introducing the first speakers. The first speaker, actually, who will be Mike Frick from the Treatment Action Group. I will introduce him. Is the co-director, one of the co-directors of the TB program at the Treatment Action Group, where he coordinates global civil society coalitions advocating for TB research and access to its benefits. As part of his work, Mike has started in TAG, a program to advance the human right to enjoy the benefits of scientific progress and its applications. Thank you, Mike, for joining us. And I will hand over to you with a question, which is the following. We recognize the impactful work done by TAG in strengthening women's right to health and to science, and including through the advocacy on inclusion in clinical trials. So we would like, and we would be interested in knowing about your reflections on this need and your work for this specific aspect of the equation between rights to health and rights to science. I'm handing over to you, Mike. Thanks.
Okay, Wonderful. Yeah, thank you so much, Silvia, for having me and for convening us on this important topic. It's not every day actually that there's a meeting on the right to science. So it's really wonderful to be here and to focus on it in the context of the Beijing Platform for Action. So our work at TAG, really starts from the belief that science is a human right and that everyone has the right to enjoy its benefits and applications without discrimination. And from our over 30 years of advocating for the science we need to end epidemics, I'm focused on tuberculosis. I have colleagues working on HIV and hepatitis. We have seen time and again that participating in science is necessary to access the benefits of science. And too often in our field, clinical trials that are testing new interventions and new tools to address TB or HIV will favor the inclusion of some groups over others. And in many instances, women remain among those groups that are left out of infectious disease research. And so I think thinking, at this stage of the Beijing platform, it's impactful to recognize that it saw clinical trials and access to medical research as an arena that required corrective action for women's rights. And we've come some way, but we haven't gone all the way. Sometimes this exclusion from clinical trials is explicit. They may be designed in a way that doesn't allow women to enroll. And other times the exclusion could result unintentionally from biases or standard practices that direct participation toward men or do not take into account sex and gender in how studies are designed and conducted or how results are analyzed. And whether it's explicit or incidental, the exclusion of women from clinical trials results in real health disparities and harms. And I want to give just a couple of quick examples of the consequences of this exclusion. The first example is from tuberculosis research. Until recently, pregnant and lactating women were excluded from nearly every clinical trial that tested new treatment regimens for TB, and to this day, they remain excluded from all registered studies of new TB vaccines. And this is despite pregnant and breastfeeding women having a higher risk of tuberculosis than the general population, and TB posing a risk to the pregnant woman, to her pregnancy, and her infant. And this exclusion has resulted in few evidence-based guidelines and treatment and prevention options being available to pregnant women affected by TB. And this is because evidence-based guidelines can't be made in the absence of evidence that an intervention works for women. The consequences of this, one illustration, is that more than 6 decades, 60 years, elapsed between when the most common TB preventive treatment regimen, which is known as isoniazid preventive therapy, was first introduced into use and when it was first systematically studied in pregnant women. And when that first clinical trial of preventive therapy was finally completed in pregnant women in 2019, researchers found that a result that surprised them. There was actually a higher risk of adverse pregnancy outcomes among women who received treatment during pregnancy. And women who received treatment postpartum had a higher risk of toxicity or damage to their liver. Both of these findings upended prevailing expert opinion. And these risks could have been recognized earlier if pregnant people had not been excluded from the initial studies of preventive treatment for TB. And identifying this unsuitability of TB preventive treatment could have motivated researchers to develop better and safer therapies sooner rather than later, not only for pregnant people, but for everybody. The second example is from HIV research. My colleagues at TAG track the demographics of people participating in HIV cure research. And as of February of this year, among 161 clinical trials of HIV cure that had presented or published results since 2018, enrolling nearly 8,000 people, fewer than 20% of participants were women. And of special concern, 5 studies failed to provide any information on sex or gender of enrolled participants. So if uncorrected, this underrepresentation of women in HIV cure science will only reinforce disparities in which women and girls face a greater burden and risk of HIV than many other groups in many regions of the world. I want to call our attention to a report released a year ago in March 2024. The Special Rapporteur in Cultural Rights, Alexandra Zentaki, presented a report to the Human Rights Council on the right to participate in science. And a central conclusion of that report, one that we support very strongly, is that participation is a prerequisite for accessing the benefits of scientific progress. And she noted that if women can't participate in science, there's no guarantee that science will be applicable and relevant to their needs. And women have sort of fallen into a category, children and adolescents or other groups that have fallen into this category that are considered to be vulnerable to scientific harm as a class. And as a result, they've often been excluded or from studies out of a misplaced desire to protect them from research. But in reality, the result has been a lack of innovation specific to women's needs. And so to change this, we have been working alongside women living with and affected by TB to increase their representation in clinical trials. And we've done this by working through community advisory boards, or CABs, to review studies as they are being designed proactively, challenging study protocols that exclude women explicitly, and pointing out areas where the design of studies can be improved to facilitate women's participation. And a particular focus for us has been on increasing the participation of pregnant and lactating women in TB research. So last year, we convened 16 representatives, including women who had had TB during or after pregnancy. These women were from communities affected by TB around the world. And we brought them together to develop a consensus position on the earlier inclusion of pregnant and breastfeeding women in TB trials. And the group concluded that while there are risks, the benefits typically outweigh these, and that they strongly believe that the exclusion of pregnant and breastfeeding women from TB clinical research is a missed opportunity to improve the health outcomes of pregnant women, the health outcomes of their infants, and the public health as a whole. And it's also a violation of their basic human right to enjoy the advancements of science. And the group went on to describe this exclusion as a form of sex-based discrimination. I think that building on this community dialogue, there have been parallel efforts among scientists themselves. The World Health Organization is now undertaking a process to develop consensus on the greater inclusion of pregnant and breastfeeding women in TB research, which should be released later this year. And we hope that this is a call to action to make further progress in this area of TB. I want to end by just reflecting for a minute that, I think consensus is just a platform for action. Our thinking has evolved very significantly. There's now talk of protecting women through research rather than from research, but action to actually include women in studies has a long way to go. And clinical trials are really just one of the many arenas for action. And realizing the right of women to enjoy the benefits of science will require recognizing that they have a right to participate in science as more than just clinical trial participants. So we're starting today with clinical trials, but I'm really eager to hear what other panelists have to say about sort of the other dimensions of women's participation in science. I'll stop there and hand things back to you, Silvia. Thanks.
Thank you so much, Mike. This was fantastic, actually, as an introduction to this specific topic, which, as you said, is not necessarily very often discussed when we talk about human rights, rights to health, or rights to science, and which is important probably to position much better. And I remember, I don't know whether you actually made it in your speech today, but certainly in your speaking points, you added this statement that it is important to protect women through research rather than from research, which I think it's a very strong, important statement for policy change and also for advocacy. So it's something that we should probably use collectively when we speak about this topic. And it's great to have you here and to have this contribution. So I would like now to check if Dr. Isabel Meleki has joined. If so, if you can unmute yourself and let us know, because we are not sure that the next speaker is ready. Not yet, probably. I don't know if my colleagues in MMV have additional information at this point. Otherwise, we will move to the next speaker. Okay, I don't hear any feedback, so I think we will move to the next speaker, checking that Patricia Kamara from CHAL is online.
Yeah.
Yes.
Hello?
Okay. Great,
Oh,
Patricia. It's a
my
pleasure
camera
to.
is... Okay, go ahead.
It's a pleasure to have you here. So actually, Patricia Kamara will help us looking at the topic of the right to health and right to science and the benefits of science from a community perspective. Introducing her, Patricia Kamara is the Executive Director of the Christian Health Association of Liberia, CHAL. And she's an experienced professional nurse with more than 20 years of experience in healthcare work, in government, private sector, in international and local organizations. So from Patricia, we would be interested in knowing, hearing what has been your experience in advocating for women's rights at the Commission on the Status of Women, and also what are the lessons that you have learned from implementing projects that address women's right to innovation and health in your countries, in your country and abroad, if you wish.
Okay, so honestly, thank you. Yeah, thank you for inviting me to this meeting, and I'm grateful. I'm sorry my camera is not working, so you will not be seeing my face while I'm presenting. Yes.
No problem, we can hear you very well.
Okay. Okay, so my experience in attending the CSW goes way back to 2006 when I was the Assistant Minister for Research and Technical Services at the Ministry of Gender and Development. And that was just after a few years after we have evolved from the war, the 14 years war in Liberia. So being the Assistant Minister for Research and Technical Services, I was representing the ministry at the CSW in 2007. When we went to the CSW, my experience with survivors of the violence on gender-based violence and survivors, and we're also talking about partners implementing these programs, became an eye-opener for me. So when we came back to Liberia, gratefully, we are happy that our president then was a female, Ellen Johnson Sirleaf. She was the 24th president of the Republic of Liberia. She served as a role model for us. And we realized that her efforts in reviving the recovery system in Liberia, improving the good governance, promoting women's rights, just motivated us more to do more work on women empowerment. So based upon our visit as the CSW, that very year we began to work at the ministry. Some of our key achievement was ensuring that we have a national gender policy that would develop and make sure that this gender policy was rolled out throughout the whole country. We mainstream gender into the public services. Each ministry or agency in the country had a gender desk. And a gender desk to be able to explain or recall women issues at those various ministries. We also developed a gender-based violence action plan. This action plan was rolled out throughout the whole country, and as a result of this action plan, we were able to have networks of journalists against gender-based violence. We were able to have networks of interreligious council group that was also working towards gender-based violence, and GBV task force set up in all counties. With this kind of achievements, we also went ahead and constructed a safe home. When we constructed a safe home, it became a means by which women were now relaxed, comfortable. They make sure that they could have access to treatment. They could be protected when they came out to speak about issues that were affecting them. And with such a safe home being equipped and being providing the support to the women, we realized that we needed to have a special court established to just fast track these cases, because one could not believe how cases were not coming in because of the support women were receiving. So rape cases were not being fast tracked by this special court. And then even a referral pathway was set up, to direct all survivors and their relatives as to how to follow your case from one step from the hospital to the court or to the police station. This kind of referral pathway was set up. And health facilities were also encouraged to provide free treatment to all women that were undergoing such a situation. It became a success story for Liberia so much that when we visited in 2008, when we went back to the CSW, Liberia were asked to showcase their success story, and we're able to not only showcase it there, but we're also called upon in Northern Ireland to go and explain our success story. What are you doing that women are so much now involved? Women are able to talk out some of the issues that are affecting them. And we even went to East Timor as well to provide our success story. But having been motivated from the CSW, as an organization, I'm executive director of the Christian Health Association of Liberia. We have advocated for ultrasound machines to be placed in hospitals and trained by women to operate these machines. Because if a woman is able to examine another woman, they are open up more to treatment. They are open up more to come for continuous treatment. So we have done that. We have also conducted a neonatal resuscitation training for midwives and put solar lights in delivery rooms in over 50 health facilities. Why solar lights in delivery rooms? In Liberia, most of our health facilities, because of the inconsistency of the electricity, sometimes deliveries are done on phone lights, cell phone lights. So therefore, we have to advocate for solar lights to be placed in delivery rooms. And these are, we are even advocating for more other health facilities to have get support for this. We have also encouraging the women, the young ladies to get involved in other skills that will promote them or carry them forward. Skills like having skills in science or technology or engineering or even mathematics. What we have seen in Liberia, most people are going for nursing. And today we need to deviate from that a little bit to go forward. So women, now we have 3 women on scholarship to have a 3-year diploma program in pharmacology. Lessons learned from the ITPT is a project that is being implemented in the most remotest part of Liberia. And it was implemented because the uptake of IPTP was very, very low in this district. And Liberia being high in maternal mortality, this is one of the programs that have helped us. The IPTP now has encouraged women to turn up for taking their treatment on time, taking the malaria preventive medication on time, which have helped to reduce stillbirth in our health facilities. And we have also realized that when you provide services to our women, they are encouraged to come back more. So we have learned, lessons we have learned so far is that for women to accept the services that we provide, it will depend largely on how we interact and engage the women. Policies we put in place by the government, it can either enable better healthcare or become a barrier. For example, in this case, the government here is advocating to only have the IPTP medication in the public health facility. But there are faith-based health facilities that are also implementing maternal child health programs. They don't have access to the medication. So through this particular project, we have an advocate so that faith-based too can have access to the medication. And this has been working very well. One thing we also realize, a lesson that we are learning from this particular project is that a multi-sectoral approach is important in addressing women issues. It's very important because it allows greater convergence, better allocation and use of resources, and it avoids duplication of effort. We have realized this, and based upon this approach, the projects have been less than a year. We can say that we have been able to have an increase of IPT visits, patients that are coming to take IPTP from 4% in 2023 to now 11.4% in 2024. So in concluding, I want to say that we cannot advance women's right to science or innovation and their right to health if women are not part of the decision-making process. We must have them be part of the decision-making process, and in that case, we'll be able to achieve what we want to achieve. Thank you.
This is great, Patricia. Thank you very much indeed. The final call for women to be part of the decision making. And indeed, I mean, it's great to hear about the scale-up project on IPTPs, which, as it was put in the chat, are the intermittent preventive treatment for pregnant women. And in MMV, we are delighted actually to work with Chal in that project. And it was also very interesting what you said about the importance, in a way, that the Commission on the Status of Women has in bringing countries up to speed with the requirements for gender and for gender equity and for women equity vis-a-vis women particularly, which also makes a good point in terms of how important that certain agendas, like the agendas that we are promoting today, become visible in the context of the Commission on the Status of Women in order to get this kind of amplification and return in the countries. That was great. I would like to check once more if Dr. Meleki, Isabel Meleki has joined, but I don't see her in the list of the participants. No? Okay, so I think we will move then to the next speaker in the list, which is Andrea Lucard. Who is the Chief Strategy Officer and Executive Vice President for External Affairs at Medicines for Malaria Venture. As part of her responsibility and also out of her personal commitment, Andrea has been a vocal advocate for integration of a gender perspective and gender equity perspective in product development and access to medicines. And she has done this both in MMV and through her participation in as a member of boards of various global health organizations. So, Andrea, we hand over to you our question, not as an MMV staff, but in general. MMV is a product development partnership. Can you tell us what a PDP is, what MMV is doing, and how the work of a PDP, actually work of a PDP have to do with the promotion of women's right to health and to science? Thank you, Andrea.
Great, thank you very much. Pleasure to be here, and really, really interesting to hear both Mike and Patricia speak. And I have a couple of comments and questions to them based on what they've said. But to address just directly, Silvia, what is a product development partnership? Product development partnership is loosely a definition of those organizations that are designed as not-for-profit organizations to develop the medicines and other technologies, vaccines, vector control, that are required for in those areas in which there is very little profit incentive for innovation. As we are mostly all aware, innovation is very, very expensive, and innovation in medical devices, medical technology has been consigned in our global environment to the pharmaceutical industry. The pharmaceutical industry has done amazing work for our health, and it is simultaneously one that is governed by the rules of the stock market and the needs for the organization to continuously produce profit. So around the beginning of around the turn of the millennium, there's some organizations that were earlier, some organizations that were later. There was a concept that we needed to find a platform, a way, and organizations that could actually develop medicines and work in innovation by harnessing both the pharmaceutical industry, but also individual donors, countries themselves, and the patients to develop new innovations for medicines. MMV is one of those organizations, and our remit is to do this for malaria medicines. Other organizations one of the organizations that I'm on the board of is the Concept Foundation. This does this in sexual and reproductive health products. There is TB Alliance. Mike will be very familiar with that. There are quite a number of others. So to the other part of the question, now most of us are based, most of us have a similar group of funders. They're largely, it's largely the Bill and Melinda Gates Foundation and multiple governments from around the world, depending on where we're placed and what our work is designed to do. So to your question about what does a product development partnership have to do with the rights of women to the benefits of science. So as you think about the populations that need to have access to the medicines and other technologies and vaccines that are needed, such as malaria, tuberculosis, HIV, these are all areas that women and men and children and elderly people and others are differentially affected by the type of disease that is being shown. Rural populations, some cases, urban populations in others. And I see that there's a question from Sanjina. Well, let's see. I'll just take a deal with that. Yes. So the obligation of the scientific community is to make sure that the medicines that are being developed, and I'll use the word medicines to mean all of those technologies, that medicines are developed are effective and safe for the populations that are to be using them. And in the case of malaria, after children under the age of 5, the people who are most badly affected by malaria are pregnant women. And when we're really talking about pregnant women, we're actually largely talking about pregnant adolescents and girls, that is, women, girls, adolescents that are in their first pregnancy. And as Patricia was noting, for example, that the IPTP, intermittent pregnancy treatment, IPTP, I've said it too many times in my life, is a crucial intervention for pregnant women. The problem with IPTP is that it's really using a lot of quite old products. We don't have new innovation in this area. We don't have new innovation for treatment or prevention in pregnant women because we haven't been able to develop the data, as Mike was talking about earlier, the data that's required to make sure that medicines are safe and effective in pregnancy. Why don't we have that data? Well, for a very, very long time, in fact, since about the 1950s, women were excluded, women in general were excluded from clinical trials. Clinical trials are very important because this is the way in drug development. First, you test a molecule in silico, then you test it in animal models, then you test it in healthy volunteers, then you test it in a small group of patients and so forth, and then a larger group of patients. If you can't actually have women in clinical trials, and particularly not pregnant women in clinical trials, you cannot test the medicines in the people who need them. And in the case of malaria, that is pregnant women. Now, we have a representation of how this has been able to change for children quite substantially in the course of the 20th century, where there was a sense that children could not adequately participate in clinical trials over time because they were a vulnerable population. And over time, it was also became clear that as children are not small adults, medicines needed to be tested in populations. And therefore, there was required both a scientific and an ethical mechanism for taking a look at how people, children, could participate in those medicines that would be effective in that population. That work is now happening at MMV and other organizations. Mike was discussing this in tuberculosis, on how do we make sure that that pregnant women can safely and ethically be included in clinical trials. Because when you're dealing with pregnancy, of course, you're dealing with two possible outcomes, or two different people simultaneously that may have an outcome: the woman herself and the baby. So this is really one of the questions that we have to focus on. To do this, also, drug development happens in a very large ecosystem. It happens with the the scientists, it happens with the clinical trial researchers, it happens with the communities themselves, it happens with the regulators. So all of the products that we take are all things that go through regulatory authorities. So amongst the things we have to change, Mike, you were asking before about who's changing, what's going to change. Amongst the things we have to change is how do we have those conversations with all of those groups, with patient groups, with the scientists themselves, and with the regulators and the communities. And I will say that just today, in fact, these two organizations that I'm so very fond of, Medicines for Malaria Venture and the Concept Foundation, are in Rwanda with 12 African regulatory agencies to indeed discuss how this work can move forward. What is the level of evidence that's required in order to decide that it's safe for women to participate in clinical trials, and then how can they do that in the process? And this is all part of MMV's initiative called MIMBA, which is Malaria in Mothers and Babies, which was an initiative that was started 5 years ago to start at where we had data and how we could safely include and expand the ways of getting to that data, so that we're starting now at MMV already in the discovery phase, already in the place before we even come into humans, even before we come into animals, to be able to understand how do we design the molecules that are going to be safe for women. Just make one more comment. This is work that's happening in the infectious disease space. And in many ways, those of us in the not-for-profit and infectious disease space affecting low and middle income countries are actually in advance of what's happening in the regulatory and pharma space in other countries, because we have such an ethical imperative to make sure that our populations are getting the benefits of science.
Great, Andrea, thanks so much. You closed the circle. Actually, we started with Mike talking about the importance of mainstreaming attention on women in the clinical development of drugs, and then Patricia took us more to the implementation side, the access to medicines, and now we come back. So it's between the three speakers, actually, we coordinated very well, even if we didn't interact in advance, in creating this storyline, which is very compelling, I think. At this point, I would maybe we would end with the presentation, and we would like to have sufficient space for discussion. So first of all, I would like to check with my colleagues if in the chat there are questions for any of the speakers that we would like to highlight. And actually, indeed, the speakers who are able to switch on the video, it's good if they are present online, yes, with their videos. I don't know, Ruth, if there is any question that you would like to highlight from the chat.
There's a question from Sandrine, and she asks that, is it safe to empower mothers to be able to test for malaria among their children? Mother-led malaria test kits and treatment for under 5 children in rural and hard-to-reach areas.
Yes, I understand that, in fact, it is not Sandrine, who is actually an intern in MMV, who is asking this question, but it is somebody else. But very good to...
It's actually Olubunmi, if she would like to elaborate on her question.
Great,
Okay.
Great. Does any of the speakers want to answer that question? Which is basically, is it safe for mothers to be involved in clinical trials?
In malaria testing.
Malaria specifically.
Yeah, so I am afraid that I don't have the technical expertise to be able to advise on that. But I would be happy to come out of this and take your information and understand from people who are actually working in the field what type of technology is currently available, and get back to you if you would like. Looks like Abna is answering the question. Abna?
Yeah, actually, in many of the endemic countries in Africa, there are malaria test kits that you can actually buy at a pharmacy. A mother can buy that and test a child. These are some of the measures that the governments are putting in place to ensure that people get tested before they take the medication. So they are test kits. Whether they're easy to use is another thing. I've tried it myself, and sometimes it's not the easiest to use. You need to have a little bit of education and be able to read. So when you think of the rural areas, I think then you need to get the healthcare workers involved to train the mothers potentially on how to use these test kits. So that would be my take on it.
Yeah, thank you. Any other questions in the chat, Ruth, that you see?
No.
Okay, so maybe, I mean, we can continue the discussion this way. I would like to ask one question. Well, no, first of all, maybe I would like to see if there are also some virtual hands raised, but I don't see anything. So we'll go actually with my question, which is to the
There's a
three
hand
speakers.
from Christy, Silvia.
Ah, okay, great. I don't know why I don't see it, but I'm glad that there is a hand raised. Please go ahead with your question.
Yeah, thank you so much. And certainly don't mean to interrupt the flow, but really appreciated the presentations by the three speakers, and was just wondering if we could also discuss a little bit like some of the challenges that you're seeing, the additional challenges. It's already a really tricky area, and it's so important to continue to push this agenda. But with regards to the current political climate in the United States and globally, and a lot of European countries as well, like I'm just curious, some of the additional challenges aside from funding that we need to start really thinking about to make some progress in these areas. And then anything that you're finding is especially resonating, especially as you talk with, different government funders and others, data points or arguments that you're making that you find are really are receptive, people are receptive to hearing that and wanting to, sort of support the cause and make sure that we are inclusive of women, pregnant women and lactating women. And I really loved, Mike, that point that you made, protect women with research versus from research. I've written that down. That's really, I don't know if that's been said before, but I think that's really genius. So thanks for that as well.
I can't claim to be genius on that. That was not my line. I don't know the origins of it, but it's a good line, and I think one we should all bear in mind. Maybe I'll start, and then very eager to hear others what they think. I mean, funding is a challenge, and I just want to acknowledge that the work that we've done on mainstreaming the inclusion of pregnant and breastfeeding women into TB clinical trials, including convening the community representatives, was funded by USAID. And USAID, their TB program, had a commitment to clinical research that included pregnant women, women in general. There was a really strong commitment to gender equity. And I think that we need other champions and funders to kind of pick up the cause and the baton now that the last 2 months have happened. I don't need to summarize that story for everybody. Another challenge is just in the United States, at least, our kind of conceptions of sex and gender that we're hoping to include in clinical research have been rewritten by the federal government, which has put out a very narrow definition of what sex means. And that's not the direction that TB-affected communities were moving in. I am a part of community advisory boards that were pushing for TB clinical trials to collect data on gender kind of expansively defined, to start to understand the extent to which TB affects people who would identify as non-binary. And, this has like real clinical import, because a lot of the TB drugs we use interact with all kinds of hormone-based treatments, hormone-based contraception, gender-affirming hormone-based therapy. So this wasn't just to be inclusive for the sake of being inclusive, which is a goal in its own right, of course, but this was to have medicine that is informed to meet the needs of people and all of their diversity, and to correct a kind of historic lack of attention to this issue in TB care. So I am worried about this agenda in the current moment, at least kind of in terms of the advocacy and the funding that we can expect from some of our traditional supporters among the US government, where we are making real progress. And I don't have solutions, but very happy to work together with others to think through them.
Great. Thanks, Mike and Christy, for the question.
Yeah, and I let me add to that.
Andrea, please go ahead.
Yeah, thanks. So I'll echo what Mike was saying about the concern about sex and gender. in the sense that even when we began looking at this at MMB as an infectious disease that's carried by a mosquito, there was a real sense in our own organization that other than in pregnancy, other than in sex, there was not really an impact on this, right? Gender didn't matter in this because it was really about sex. So we were really in the it's about sex. Only we all know, and it was exactly as Patricia was saying, what she said, what did she say? Women operating machines go when more and more women seek treatment, right? Health-seeking behaviors, occupational behaviors, all manner of things, all gender-related things, that is social construct of sex, all of these things are actually affect the data we can gather and the way that people move forward. And so one of the things that concerns me in working on the advancement in science part of things is the temptation to, and I've seen it actually in international sessions right now, the temptation to take gender away as if this were not also a construct of science in scientific inquiry. So we have to be very careful of that, because if we just say this is about it, we won't get there. I will say that what I have seen in these same international arenas is countries in the North actually beginning to identify and look for safety signals and efficacy signals in products that are being used in their own populations. I will say that the UK government, for example, right now is very interested to be sure that products that are being used that have not been tested in women and therefore need to be seen in clinical settings, they're looking to figure out about the safety of this. So as long as we allow this to be an all of world question about what medicines are safe, we actually can carry each other along in ways that in the past has been, it's about the North, it's the South, it's the infectious disease. It's not. It's about what do we know about how compounds are active in human bodies. And this makes a difference. And this is exactly, this was a question I asked of these government representatives. Safety is one, safety and efficacy. How much money you're spending on inefficacious drugs or drugs that are literally unsafe is a major question that's moving forward.
Thank you so much.
This is great. Thank you. This discussion indeed that's also needed to take place in this kind of event, because indeed there are a lot of environmental determinants that impact actually on the policy change, not only on the discussion that we are having now. And I don't see any additional hands raised. Ruth, is there anything new in the chat?
No, Silvia, but I see Patricia had unmuted.
Yes.
Perhaps she wants
Yes.
to speak.
Great, Patricia. Yes, please provide your
Okay,
input.
sorry.
We
I'm
didn't
trying
want
to
to
find
force
where-
you, but
Yes.
yeah, it's great that you can.
I
Please
wanted
go
to
ahead.
raise my hand, but I just can't find where to go to raise my hand. However, I just wanted to say that with the withdrawal of support from the USA has brought in a shock to, especially to the health sector, because most of our support was coming from USAID. So with such an abrupt, very abrupt withdrawal, has led the government to now see what they can do to maybe increase taxes in some of those areas, so that the funding from those taxes can be given to the Ministry of Health to try to beef up their program. While that is also happening, there are a lot of reprogramming of activities right now going on at the Ministry of Health. That's what is happening. Yes, because the work has to go on. At the same time, while they are doing reprogramming, they are also seeking funding from other partners like the Africa CDC, and those are the kind of support they are now looking for from elsewhere, because they have now realized that in the USAID fund is no longer going to come. So we need to find other means, and that is what we are doing now.
I have to say, Patricia, it's really an important thing to hear and to know. This is one of the places where obviously as this entire global health architecture, not just global health, but global development architecture gets rapidly dismantled. One of my colleagues in a meeting I'm in today was saying, well, when you cut down the big oak tree, that's the chance for the smaller trees to grow. And I think that is one of the things that we're hearing from across the continent, that people are ready and making it happen.
That's true.
Yeah, very good point, and great contribution actually from Liberia, Patricia. Right, so I don't see anything else. Or hear anything else. So I would maybe start with, or end with a question to the three speakers, but maybe broader, which is the following. What can we do then to take this agenda forward in policy change, in the human rights and global health policy change processes, including in the next phase of the Beijing Platform for Action and beyond? So I would like certainly to ask this question to the three speakers, if they have any reflection on this point, but also open to all the attendees to put their own views and suggestions in the chat, if they wish, because we would like to compile actually these ideas and then maybe come up with something for this group or for a community that could be interested in this topic. I will go in the order of the speeches, so we'll ask first Mike, unless you want to pass over to somebody else. Please go ahead.
Yeah, no, I can start. I don't want to both open and end the meeting, so yeah, I'll go first. Look to my colleagues to follow. I think, so just very generally, one thing we should all do is just talk about the right to science more. You know, as somebody who's been working on the right to science, I have to say it's still a very small and lonely space. There's a lot of attention to human rights generally, to right to health, but for a very long time, the right to science was actually called by human rights scholars and practitioners the forgotten human right, because there wasn't very much legal writing on it. There hasn't been a lot of litigation. It hasn't been applied very often. That is starting to change, and it's really great to see more and more people and more events like this pick it up and identify it. But we need more people talking about science as a human right and in relation to specific issues like women's participation in clinical trials or in medical science. So if you're interested in doing right to science work, would love to hear from you and would love to work together with you on that, because it's something that we're very interested in. I think more specifically, on the topic that I presented on, there's just a lot of learning that we can do from each other. So in TB, the work that we've been doing with community and scientists to include more pregnant and breastfeeding women affected by TB in clinical research is really borrowing a page from work that was done in the HIV field. They had developed a framework to include pregnant women in HIV clinical trials. And we basically, in TB, started by looking at that framework and seeing what about it applies to tuberculosis, what needs to change, and how can we go further. Listening to all the interventions about malaria today, it strikes me that there's been a lot of work done in malaria as well, and we probably should have been looking at some malaria frameworks. So what are the things that we can do together? Often, clinical trialists will say to us, well, there's this barrier, to including pregnant people. We can't find them. We can't recruit them. We need to buy expensive trial insurance in order to include them. The regulators won't accept it. And I think if we can share thinking and share answers, we can begin to overcome some of these obstacles, like learning that there are regulators from the African continent meeting today to discuss this very issue. It'd be great to hear the outcomes of that meeting so that in the TB world, we can refer back to them. So I think sometimes there's a tendency to kind of reinvent the wheel and feel like we're the first to do something when in fact, like people are working alongside us, and it'd be great to tap into that. So I'll just say those two things: talk about the right to science, and then look kind of outside of our specific disease areas and learn from each other. I'm a TB person, but it's been great to hear about malaria today, and we should do more of that kind of cross thinking.
That's great. Collaboration across health areas of major interest to to women and gender equity more in general. Yes, great. I would ask then Patricia to provide her thinking on that, on this topic. You need to unmute yourself if you're trying to speak. I will try to do it myself for you. I cannot do it. So let's move to Andrea, and then if somebody can help, maybe Patricia, who I think is under the name of Ruth Agala in the list, to unmute and have also her inputs after that. Let's start with Andrea.
Great, thank you. Yeah, Mike, I couldn't agree more. And I would add a little bit, even a bit more, that the language of women and health has largely been what I have heard called bikini medicine. You know, anything that's from here to the you know, to your hips is women's health, and everything else is not. And therefore, when you start thinking about infectious disease, when you start thinking about heart disease, you start thinking about pain management, on and on and on, we're learning more and more in the science about how different people, a diversity of people, respond to this. One of the things I think is probably really important for us to do, as you were talking about the challenges that people rightly come forward with. This is tough stuff. These are difficult questions about ethics. As an example, what MMB did in terms of looking at ethics boards was really just move to communities with trained ethicists and said, you know, how do we approach this? How do we approach the ethical questions? Again, going to the African regulators. Other questions about trial insurance, all of these things are being worked on piece by piece. So I would advocate for us to advocate in a way that speaks about this broadly in the human rights, with the human rights framework, which is extremely useful, but also advocate about it narrowly. Be able to speak to those people who have the opportunity to make some changes in these kinds of areas. I mentioned the MHRA just now. Be able to think about advocacy in those places that people are legitimately saying these are barriers. Given that much of this work is not very well funded, we need to be sure that we're going to the insurance companies and speaking about insurance and understanding what that looks like. So this is actually something that can be overcome, and that is very much a role of advocates to quite get at the specificities of things, even as we're holding in the larger picture, and to recognize that those things are not disease specific. Regulatory trials are a form of approach to medicines that we really can that we all have to approach, even if we all have to deal with, even if our diseases are different. So large approach, how do you think about human rights and what this means? And then specific approaches, who do we specifically have to talk to in order to be able to make these things change? And I think Patricia has now come back on, so let me stop here so she has a chance.
Yes, okay, my internet went off. So for us in Liberia, I will really encourage our African leaders to have a political will for women empowerment. We need to continue to push this. If there is a political will, a lot can happen in the country. When the female president was in power, a lot happened for women empowerment. There was a great change. Everyone felt the change and they were all happy. But now that we have different leadership or so, and that willpower is not there, you can see that all of the gains that were made during that time has begun to be reversed. We need to encourage to have more opportunity or to create more opportunities for our young women and girls to go into the field of science, technology, engineering, or mathematics. If we want these girls to have jobs tomorrow, to be able to have access to the labor market, we need to empower them today. That's what I wanted to let you know, or to pass across. Now let's make sure that it gets up to the PJ platform. Yeah.
Great. Thank you very much for these contributions. They were really very helpful at this point of the discussion. We have also the chat that has become quite lively on these questions. So we have a number of points of interest. We have Stephanie, who has suggested to think of submitting manuscripts, for example, in perspectives, and she's also making an offer actually. On that, we had commitment or an interest in working on that from Nigeria. And there is a question about how we can enter this space on the right to science, which as other areas may be a little bit closed and introverted and not necessarily open to perspectives, but between the speakers and the attendees today, we probably have some entry points. Happy to receive additional maybe answer to that point made by Laura. So I think we have quite a lot already how to work on ecosystems, the importance of, yes, indeed, putting on the agenda the work on ecosystems for integrating this topic in it. Right, I will ask if there is any final comments or questions, I will maybe just add a few points on follow-up steps that we may want to take. Okay, if not, we will getting actually more or less to the conclusions of this event. On our side, we will certainly compile a summary of the event, or at least, focusing on the outcomes of these discussions, the main points that have been raised, and can be taken forward and possible next steps, and share it with all the participants so that are interested in staying in touch, at least on this topic. Then, the Commission on the Status of Women is about to end at the end of this week, and we will be here with pleasure actually from people who are active in the Commission discussions on any points that are relevant to what we discussed today, and we may want to take forward as a follow-up to the discussion of the Beijing +30 debate. And also we will have other important advocacy moments during the year for us, for the global health community. One is the World Health Assembly in Geneva in May, where there will be an update on the global strategy for women's, children, adolescents' health. So many of us are also active in that process, and we will keep this group informed on opportunities and activities that we may organize around that and around this topic, or linked to the topic that we discussed today. So that's a little bit the points that we would like to add, and we will add the points made by the speakers and by the participants. So at this point, I would say that it's time to wrap up this meeting, and would like to thank the speaker who attended and the discussants who provided really a very valuable contribution, the MMV team who helped in pulling this together, and the co-host organization, again, Speak Up Africa and the Treatment Action Group for their effort in publicizing the event and making this a very participative discussions with a number of attendants. The interpreters, of course, who are always very crucial in this kind of events and very busy. So thanks a lot to the interpreters, and also to the participants, because they have actually invested almost an hour and a half of their time to join and to discuss with a number of great suggestions. So that said, thank you and goodbye, because we will continue to be in touch in the next few weeks and months. Thank you very much.
Thank you. Bye-bye, everyone. Thanks for coming.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Bye.